What do you think are the most important elements of treating somebody who's suicidal?
I think the first one is the strength of the alliance. That most suicidal patients encounter a clinician that says, you can't do this. I'm not going to let you do this. And for a lot of suicidal people, maybe right behind their suffering is a feeling that I've got this. I've got a way to end my pain. And so when a clinician encounters a patient that way, you have an instant power struggle where the clinician says, you can't do this, and the patient says, well, it's my life, and who the heck are you to tell me what I can do with my life? And this is, that whole debate, I think, undermines the idea that we would actually work together. And so in the Collaborative Assessment and Management of Suicidality, or CAMS, which is a approach that my group has developed and where we're doing clinical trial research now on a treatment version of CAMS, we literally and figuratively get up out of the chair and sit next to the patient to go through the assessment and treatment planning process together, so that in looking at suicidal risk and deconstructing it with the patient, we're actually forming an alliance because we're working to see the struggle through the patient's eyes. And then we pose to the patient, if we can meet or identify the things that make you suicidal in the first place and get a legitimate, meaningful response to those issues and problems, would you need to kill yourself? Can we, in effect, think of suicidal thoughts and behaviors as problem-solving approaches for the patient? But can we offer and perhaps convince you that there's some other problem-solving ways of getting those legitimate needs met and making systematically, or eliminating suicide systematically as a means of coping? So it's a much more sort of forthright discussion. There's a lot more sort of discussion about the pragmatics of all this. I oftentimes shock clinicians by saying, or role playing or showing in videos that you can reassure the patient that they can kill themselves later, when they're not in treatment. But what if they're going to be in treatment, that they should be in treatment and really learn, because they have suicide, really they do. We can't lock them up anymore forever. That they can really try to learn about a different way of problem solving and a different way of making their life livable. And that's what we want to focus on. And in this really peculiar or paradoxical or motivational interviewing kind of way, when you reassure the patient that they can kill themselves later, because the fact is they can, then you've done something very powerful, which is to say, but do you have to do it this minute? Can you delay it, for now? Can we find other things that you can do instead that would eliminate the need to actually have to take your life? And that the message in CAMS, at least in my approach to things, would be, how do we keep you out of the hospital? So for years, really, for hundreds of years actually, the society's response or the clinician's response to a suicidal person is, let's put you in the hospital. Let's get rid of you, in effect. Let's lock you up. And that could have been very well intended or benign in its intent. But I think it's a very different approach to say, well, the law says this, and if you're in imminent danger, I'm required to make sure that you're in a protected environment. So if we can kind of keep you from imminent danger, is there a way that we can work together with a viable outpatient treatment plan that helps you fight for your life and find a way to make your life livable? I think you can sidestep the power struggle, and I think you can work with patients, and I think you can treat them with decency and respect and not shame them for what they're feeling or what they're thinking about doing, and really make a pitch or an argument for an alternative model. Harry Guntrip, the psychoanalyst in this British school camp, used to talk about psychotherapy being the rival policy, to what you might say is the voice, to sort of the inner sort of torture or the what Fairbairn referred to as the internal saboteur, and what your group would call the voice, these sort of internal messages. And so when a psychotherapist moves in and tries to be comforting or soothing or supportive or affirming, as you know, Lisa, that's very discrepant from what they've heard or maybe know in their internal world. And so when you offer this rival policy, you do it with respect, and you dangle the carrot, and you try to make it attractive. And you can think of it as a horse leading a horse to water. You can say, this is beautiful, delicious water. It's displayed here in a lovely trough, but I can't make you drink it. But I'd like for you to have a taste. And so it's a more strategic, more pragmatic way of engaging the patient and really trying to convince them that there's everything to gain, nothing to lose, by seeing if there's a way that we can rescue you and help you cope, deal, feel differently about yourself, and ultimately make your life worth living. And our data shows that we can take, especially males who might not be good treatment seekers, which we pretty much know, who are really good at killing themselves, and we think our treatment is a kind that engages them in such a way, and we got some data to this effect, that they can resolve their ideation 100% in 6 or 8 sessions. And our thinking is, or our interpretation of that, or mine is at least, is that people who are really good at killing themselves, especially these men, are, I think also, with some variation, also really good at getting better. If you give them the right tools, the right support, and a strong alliance, and make the performance issue not how well you're going to kill yourself, how well are you going to fight to save your life. And if you think of suicide as problem-solving behavior, and then Marshall Linehan says this as well, substitute other ways of coping and problem-solving, then effectively you've eliminated the need to be suicidal in the first place.